Hello and welcome. I'm Steve Clements, editor-at-large of The Hill. Thanks so much for joining us for our program today during Diabetes Awareness Month called Modernizing Diabetes Care, a discussion on modernizing health policy and practice to improve care for persons with type 2 diabetes. I'd like to thank our sponsor, Eli Lilly, for making these discussions possible. Today, care for persons with type 2 diabetes has reached a critical juncture as modern tools and approaches have the capacity to improve millions of lives. But to achieve these results, health policy and practice will need to keep pace with both changing needs and innovations. How should we be modernizing health policy and practice to drive better health outcomes with people with type 2 diabetes? How can health policy expand access to innovations and increase equity, which is a real problem across a lot of healthcare arenas, but particularly in this one? Are we adequately adhering to and leveraging and evolving treatment guidelines and quality metrics? And given the tools that exist, what quality of care should patients expect from their medical providers? We've gathered the experts to answer these questions and more. Before we get underway, a few housekeeping notes. You can tweet us at The Hill Events using the hashtag #TheHillDiabetes. We're broadcasting live, and we're going to take your questions throughout the program. And if you experience any trouble with the live stream, don't throw your computer out the window. Just refresh the page. Hopefully that will fix it. My first guest today is a member of Congress and a doctor himself. Congressman Michael Burgess, who has been a great friend of The Hill, has practiced medicine for 3 decades before coming to Congress. He's a member of the Energy and Commerce Health Subcommittee and the Diabetes Caucus. Congressman Burgess, it's always great to talk to you. Look, I mean, this is a chronic national problem. It's a systemic problem for the health care of the country. And I'm just interested in your many years of service, and you're one of the leaders in the Doctors Caucus in the House. What aren't we doing that we should be doing to change the game on diabetes care? You sound like you're muted, Congressman.
Thank you. How do you sound when you're muted? Oh, you don't make a sound. Look, one of the things that's perplexed me over a good deal of time that I've been here is it's one thing to say we've got to have the proper environment to treat someone, but the cost of medicines, in this case, the cost of insulin, has been a barrier for some people. And it actually attracted a good deal of national attention a year or two ago when prices seemed to be increasing more rapidly than was reasonable. And it's about that time that I came across a paper from Pharmaceutical Technology that looked into the benefit of providing the rebate for the sale of a vial of insulin to the patient at the point of sale, regardless of coverage, regardless of insurance, regardless of if they're self-pay, if they're Medicare, Medicaid, or commercial insurance. The actual benefit of that rebate goes to the patient at the time of sale. I like conceptually for money to follow the patient in instances like this, and this seemed like something that was a good arrangement. And their study, which they did show a reduction in out-of-pocket costs by several $100s a month. But I think there's also a bigger picture there. If there is increased compliance because someone isn't worried about how they're going to obtain or pay for their medication, you are going to increase compliance. And one of the worst things that can happen to a diabetic is they get out of control. And one of the worst ways to get out of control is to have restricted access to the life-saving nature of insulin. So that was one of the concepts when we debated some bigger bills with drug pricing in 2019, and then again more recently in the Build Back Better Act. I still like the concept of let's involve the patient and make whatever rebate is going to be paid available to the patient at the time of sale.
I mean, that's fascinating. We just had a discussion actually earlier today where one of our participants shared the notion that costs throughout this process end up becoming an inhibitor. And then when you look over, different lines of society, racial, socioeconomic, those really have a disproportionate impact on certain communities to stop them. And he said we really need to kind of get our handle around that. And I guess, given the size of this, with 34 million Americans with diabetes, 88 million potentially pre-diabetic, it's a big footprint issue. And from a science perspective or a health policy perspective, I just wonder, and you know this much better than I do, are we locked into the way we think about diabetes from 10 years ago? Are there things we ought to be thinking about? What are we doing, given all these big revolutions in technology we have, to say 10 years from now, this is the aspiration of where we'd like to be?
It's a very valid question, and one that I ask myself all the time. Are we coming up with a 1970s solution to a 21st century problem? And look, in just the advent of the continuous glucose monitor, what is the biggest complaint that you got from diabetic patients was, I don't like to stick my fingers in order to do a blood sugar check, and I've got to do it 4 times a day. But then the advent of the continuous glucose monitor, so it's not just a 4 times a day check, it's continuous throughout the day. And you can see, the patient can see the impact of choices they make, behaviors.
Hi, can you hear me?
Yes, I can. Can you hear me?
Yes.
I don't know who we're hearing,
You
but
are
I hope
set
they
to
get out
go
again.
live in
Folks,
about
I
9
need
minutes, so I'm
listen
just
to
going
our
to do a
team,
quick
please.
audio check. Could I have you
Okay.
count to 5?
Congressman, sorry, I don't know what's going on. Everyone, can we make sure that we drop whatever feed? Thank you. My apologies, Congressman. Go ahead.
The continuous glucose monitor really does change the equation. And 10 years ago, of course, that wasn't readily available. Now it's becoming more and more available. The FDA, I thought, was a little bit slow as far as approving things referred to as the artificial pancreas,
Right.
where the insulin pump is paired with the information from a continuous glucose monitor to really sort of eliminate some of the difficulties you get into and allow for those minute-by-minute decisions to be studied by algorithm and administered in a more straightforward fashion. I think artificial intelligence, or machine learning, if probably a better term to use, I think that is going to have an impact on how care is delivered in patients who have been diagnosed with diabetes. But look, here's the thing. Well-controlled diabetes costs a lot less. If you're talking about what is the cost to Medicare, Medicaid, or an insurance company, or patients' out-of-pocket costs if they're uninsured, it's much less expensive to manage someone who is well controlled. And one of the arguments that we had back in I guess now it's been 20 years ago, when Part D was being contemplated in Medicare, how are you going to afford medicines for people? And the statement was made, well, Medicare is going to end up paying for an amputation. It would be a lot less expensive to pay for insulin so that the amputation is never necessary. And that's sort of the mindset that you have to have. The cost of doing nothing is substantial.
That's a very stark conceptualization. Thank you for putting it in such blunt terms. But Congressman, when I've talked about healthcare and any of these issues, and we're in like a silo today talking about one aspect of it, but I remind people there are a lot of players in the healthcare system. There are pharmacies, there are pharmaceutical research companies, there are insurers, there are pharmacy benefit managers, there's Medicare, a lot of different players, and so in that, there is, there is incentives challenges on occasion to how to get the equation right for the patient, and not every patient is the same. You have not supported the Affordable Care Act. I'm just wondering, when you kind of look at that health ecosystem, and if we're to basically look at ways to get health care better and right, I mean, maybe that's too big a question, but what are the dimensions of it that you think can be shifted so that we're, beginning to knock diabetes down a bit as a challenge, beginning to get this? I know that the cost of drugs is one aspect of it, but are there other parts of the health ecosystem that you think need to be addressed?
Sure. I am generally not a fan of consolidation in healthcare. I think it has not worked to the patient's benefit. But you look at the situation we have today where a single company may own the insurance company, the provider network, the PBM, and the dispensing pharmacy. If that is true, if all of those are aligned under one roof, it seems like diabetes would be a situation where it's tailor-made. Let's do the right thing for the patient that happens to be happily the least expensive option, which is to provide the medicines in a timely fashion so the patient doesn't have to worry about or try to restrict their access to medication. They can remain in tight control, and if necessary, provide them the ancillary tools. You would never try to manage diabetes without some type of glucose monitor, and the continuous glucose monitor, I believe, is going to replace the intermittent monitoring for the most part. Why would a large insurance company / provider network / PBM / dispensing pharmacy, why would they not want to put all of the tools necessary for the correct and accurate management of that patient, which again turns out to be the least expensive type of care to deliver? Someone gets out of control and ends up in an emergency room in diabetic ketoacidosis. That is a phenomenally expensive healthcare interlude. Far cheaper, far more straightforward to take care of things as and keep the patient well controlled and educate the patient as far as what are acceptable parameters for their continuous glucose monitor. But it's let's utilize, all hands on deck. Let's utilize all the tools at our disposal. Now, Medicare is perhaps an opportunity where this also could come into play. Medicaid has a few more variables, but in the managed care Medicaid model, there are also some opportunities there. So these are things that I think where you integrate the entire system. And again, no fan of consolidation, and I'm not making an argument for consolidation, but if you have consolidation, why not make it work out well for the patient?
Thank you for that. One of the other areas I've been interested in is sort of advanced research and where the dollars are going. And if you kind of look over time, this arena of diabetes has had a sort of smaller share, in my view, data-wise proportion, if you look per capita over time. And again, coming back to the question of looking at what we do in advance, my understanding is that part of the new legislation that has just been passed, signed, and I may have some of this wrong, is that a new ARPA-H platform will be built that's sort of like an ARPA, the Advanced Research Projects Agency of the Department of Defense. Now we're going to have an Advanced Research Projects Agency of the National Institutes of Health to begin looking at certain of these areas. I know there's a lot of enthusiasm in the diabetes community for advanced research there. Are you hopeful? Is there a bipartisan support around the notion that more research dollars being poured into this may give us, the next to the CGMs, the glucose monitors, but the next advances in treating this?
Well, obviously that would be the goal. I don't think ARPA-H has quite made it across the finish line yet, but there are a number of people who are talking about it. There, of course, there will be the standard appropriations for the National Institute of Health that will come through before the end of this year, where certainly some attention should be given to this field. ARPA-H may be part of the next iteration of the Cures bill that, remember Cures for the 21st Century, that was passed back in 2016. There is a new version of that is now being shopped, and the ARPA-H concept is an integral part of that. There are other members I know on the committee who have introduced their own standalone products for an ARPA-H type product. But I think you see, and this is bipartisan, I think you see pretty widespread support for, and it's not so much taking it out of the realm of the National Institute of Health, but how can you deconflict some of this stuff and get big things done with less burden and the deliverable to the patient in a more straightforward fashion?
Well, thank you. Congressman, we are taking questions from the audience, and we have a good question for you from Kevin Donnelly. Kevin?
I'm Kevin Donnelly, president of DHI Advisors and strategic advisor to Fruit Street Health. Intervention at the prediabetes stage would greatly reduce morbidity and mortality. Programs such as the CDC's Diabetes Prevention Program have shown excellent results, Yet CMS doesn't reimburse virtual DPP. Why not fund the programs that work in modalities that reach citizens in their homes?
Thank you, Kevin. I think this comes along the lines of what you're talking about. Prevention makes a lot of sense. But Congressman, your thoughts?
You're asking me to justify why CMS is not doing something that they should be doing? Don't put me in that position. But he's right. If the CDC has promulgated guidelines, the barrier to implementing those may be the lack of reimbursement for, and CMS has at its disposal the ability to do that, at least within the population that they control, that is patients on Medicare and Medicaid. There is within the Department of Health and Human Services, created in the bill that was the Affordable Care Act, another part of the agency called the Center for Medicare and Medicaid Innovation. And it seems to me that this would be an ideal activity for CMMI to undertake. CMMI is supposed to demonstrate savings in order to justify its demonstration projects, but this seems one where the savings would, in my opinion, would be pretty straightforward and pretty easy to identify. I will say one of the problems that we have across the board with doing things at the federal level is the Congressional Budget Office has been in all the headlines the past couple of days for some other reasons. But the Congressional Budget Office will look at things in 10-year increments. And one of the difficulties with that is anything in the preventive health space shows up only as a cost because the benefit is going to be several years out. This is one of those instances where I think the benefit is measurable, and yes, while it may be in the second decade that the CBO would have to score, the CBO should be able to take a look sort of into the future as to what the savings would be for the active management of the pre-diabetic.
You know, I just want to tell our audience that I interviewed Representative Raul Ruiz recently, who's a Democrat in the House, and he basically exploded on TV over exactly the same point, that there's a lot of frustration about the disconnection between making both financially but also health-saving investments, but not having the benefits scored and the savings scored. And so there may be an opportunity across the line to work on some of those issues.
I have been doing that for the past many years. It's difficult because you're involving several committees of jurisdiction. It's not just Energy and Commerce. Dr. Ruiz and I both serve on the Energy and Commerce Committee. I'm also on the Budget Committee, and they'd have a part of that as well as both the Senate counterparts to those committees. So that's the difficulty, is sometimes the committees of jurisdiction can work at cross purposes. The ideal world is we would work on what's best for the patient.
Representative, just real quick, last thing, I want to give our audience an understanding. You know, you're out there in Texas and you're talking to your constituents. You're a member of the Diabetes Caucus. I don't know how to put it, but how big a deal is this to your constituents? How much do you feel hope and frustration and connection with your constituents on the subject of diabetes care?
Well, certainly there was a lot of anticipation for the so-called artificial pancreas, the ability to get glucose information without sticking one's fingers. I know I heard from groups of diabetic patients for several years that was one of their chief dislikes about how things were managed with their condition. So, you know, the cost of care, cost of medicines, and this is not just true in diabetes, the cost and complexity of care across the board is one of the things that I think we as policymakers, we need to pay attention to that. It's all well and good to say we're enacting a new policy or a new program, but every time there is something that is pushed out that's a little bit different, we add to the complexity that the patient then has to navigate. And it's not always easy to navigate all of the different parameters that we'll put out there and the sort of between the patient and their doctor and their medicine and their better health.
Which do you prefer better, Dr. Burgess or Congressman Burgess?
Dr. Burgess polls a lot better than Congressman. So mother always called me doctor, and that's what I prefer.
Well, Dr. Michael Burgess, who happens to serve in the House of Representatives from Texas, member of the Diabetes Caucus, thank you so much for joining us today.
Great, thank you.
My next guest is Dr. Robert Gabbay, Chief Scientific and Medical Officer of the American Diabetes Association. The association provides clinical practice recommendations or standards of care for diabetes. He's also an associate professor at Harvard Medical School and has focused his research on improving and enhancing the lives of people living with diabetes. Big welcome to Dr. Gabbay. Doctor, you heard perhaps some of my conversations with the congressman. Look, I've talked with Michael Burgess before, and he really does care about these issues, and you can kind of feel that in the conversation. And particularly the one I opened with is just say, hey, what can we really do to be game changers? You're at the sort of mothership of patient focus connected to the field and profession. And I know you've recently had some recent conferences on looking at everything from standards of care to metrics and other dimensions, but if we want to sort of come together 5-10 years down the road and have seen some levers moved, which ones are you advocating we shift?
Well, thanks, Steve. I think there are a number of important issues, and some of those you heard from Dr. Burgess or Congressman Burgess, who's been a great advocate, as has the Diabetes Caucus more broadly for a number of agenda issues. One of the things we realize is that there's been a great deal of innovation in the world of diabetes, but it's not reaching all people, and that's where we need to do better. So improving access to the right treatments is critically important. And the American Diabetes Association last year launched an effort, Health Equity Now, with the Patient Bill of Rights, that essentially places the importance of access to the right technology to manage one's diabetes, the right medications, to the right treatments, as at the forefront of where we need to do better. So that's certainly one big area. Another big area is around access to healthy food. We know that 23% of people with diabetes live in food deserts or food swamps. And so you can educate all you want about what's healthy, but if that's not accessible or affordable, people don't have access, and sadly, their outcomes are significantly worse.
I think that is such an important message, and I hope people are listening. But let me ask you this, and we didn't coordinate this. I just want to know, if you were to go to Baltimore, to a zip code in Baltimore where there is a life expectancy difference between certain areas, nice areas of Baltimore, and where people are rich and wealthy and have resources, another part is a 20-year difference. And so when you talk about food deserts and you talk about just different socioeconomic environments, different racial environments, I just want to know, I want to hear someday somebody in this field say, we've gone into this zip code and we have taken these steps and measures and we've changed the direction for a lot of folks, and we've found some best and promising practices to build on, as opposed to continually to talk about the gap. I'm editorializing here, but has there been any play that has done that has begun to look at best and promising practices in the trouble spots?
It's a really important point, Steve. So two things that we're focused on at the American Diabetes Association is one, this year, targeting our research funding around addressing health disparities. And when I say addressing health disparities, it's exactly what you were talking about, not just measuring it and saying that there is a gap, because we know that already, but what are interventions that can be done to mitigate those? So that's one big area. The other is that we, through our Health Equity Now platform, we've partnered with large interests in various communities to do scalable pilots that could really demonstrate how we could do better. And whether that's in Columbus, Ohio, and thinking about how we can improve access to continuous glucose monitors for people of color, to with Abbott, to working with Walmart in the Chicago area to significantly improve access to both healthy foods and the right treatments. We're building this network of understanding of what works so that we can scale it.
Another big question I have is, while type 1 and type 2 diabetes are driven by such different factors, oftentimes the prescription or the pathway to deal with those challenges are similar. But I know you've been working a lot on personalized medicine and personalized approaches, which I find to be very important in this, because everyone sits in a slightly different world. and with slightly different pressures. And I often feel like, with someone whose family has suffered a lot with obesity challenges through multiple generations, and people say, well, just pick yourself up and get control of this. It's not always that easy. And so part of the question is, in the personalized medicine field, what can be done to begin to get people where they're at, as opposed to one size fits all sort of prescriptions that miss a lot of people?
We're really on the cusp of a new level of understanding of how to really exercise precision medicine to ensure that the right person gets the right treatment at the right time every time. And it's having, we are now in a technological level where we can have that kind of data that is necessary to be able to identify the specifics of an individual and what might be effective for them, whether that's the way we message, whether that's using digital health tools, whether that is ultimately understanding which treatments are going to be most effective for which individuals. We're now at a point where we can really start entertaining that in a really productive way. So this is very exciting.
We have a question from our audience named Larry Holman, and he asks, how can diabetes be prevented? Wouldn't it be more economical to prevent the disease than to manage it? I mean, it's an honest question from the audience. What are your thoughts? This is the kind of question the public needs responses to.
Absolutely, and that goes to what Congressman Burgess was talking about. So, there is the diabetes prevention program. So the good news here is, in terms of preventing type 2 diabetes, we have the science, we have the knowledge of what works. There was a study funded almost 2 decades ago, the diabetes prevention program, that demonstrated that you could reduce the risk of developing diabetes by 2/3 by a lifestyle change. And now it's about implementing that change more broadly. And so there is funding for programs that deliver the diabetes prevention program. The American Diabetes Association has one of the grants from the Center for Disease Control to do this. What we need to do now is scale that dramatically, because although it is reimbursed and it is available, only a minority of the people that could benefit from that kind of prevention methodology have really had access to it. So the good news is we know a lot of what works, and now we have to scale it.
Robert, I want to ask you a question likely to get me in trouble with some folks, maybe, I don't know. But I'm doing my research for today's program. I learned about the term clinical inertia. This is my new go-to term, because across a lot of health, I actually haven't seen this term in practice. I'm a layperson in this, but when we talk to people about, cancer, we talk about lots of other both health maladies and chronic conditions, and you sort of look at the unevenness in America in terms of providing health care to that patient. I just know from my own family's experience that if you're in Bartlesville, Oklahoma, you may get a different message than Dallas, Texas, get a different message than in, near Johns Hopkins University or somewhere, that there's a wobbliness of information and practice out there. So clinical inertia is my new favorite term. So the question is, how do you get beyond? So my understanding, clinical inertia is one of the areas that the diabetes community, particularly those trying to advance it, are very worried about. What kinds of incentives can we put in place so that those health providers are out there, not just I may be saying this wrong, resting on their laurels and doing tomorrow just pretty much what they did yesterday, and begin enveloping that patient with new methodologies, new practices, and opportunities. Is that a fair way to frame it?
So there clearly is a need to incorporate new treatments and have more people have access to it. So as an example, there are 2 classes of drugs that have been demonstrated over the last few years to significantly reduce mortality, death, and cardiovascular disease, which is leading cause of death for people with diabetes. Those are SGLT2 medications and GLP-1. And I didn't invent the names. They're not intuitive, but they're a class of drugs, 2 classes of drugs that are available. So what percent of people that would benefit from those drugs based on current guidelines receive them? Only about 15%. 20 at best. And so we know that we could do better. It's a complex system. Access involves payment. affordability, and something that we're certainly working on. But it's also knowledge. And I think on the clinician side, I think there's a knowledge gap, but it's not just knowledge. What we need to do is redesign the healthcare system so that doing the right thing is the easy thing to do, and remove those barriers to move forward. We also need people with diabetes, particularly type 2 diabetes, to understand that the nature of the disease is that it tends to be progressive, and that what works at one point is not always going to work in many cases, and one needs to add additional therapies to stay at the safe goals for blood glucose levels. And so there are a number of issues related to this. We at the American Diabetes Association have an initiative called Overcoming Therapeutic Inertia, this idea that therapy needs to be advanced. Someone comes in, their blood glucose levels are too high, and there's no change in therapy. That shouldn't happen. One needs to be able to make the adjustments to optimize people's health.
Just real finally, unfair question. You've been at the ADA for a while, and you're sort of the Wizard of Oz there. I think you know all this stuff going on. But I guess my question to you is, in terms of the ecosystem out there, and not just the part of it that you're in, do you feel like there are elements of it that are falling backward? Do you feel like we're stuck in a rut, or are you optimistic that things are beginning to tilt forward, that a lot of the challenges we're talking about are getting squarely addressed?
The pandemic has been devastating for the diabetes community. As much as 40% of the people that died from COVID had diabetes. Wow. So that has put a big challenge ahead of us. We are slowly coming out of this, and one of the key messages for us at the American Diabetes Association is to ensure that people get back to get to the care that they need, because many people deferred their care. I am encouraged about the future. I think there's a lot of alignment now. The adoption of telemedicine and digital health that we were, in a sense, forced to because of the pandemic, have been new tools to be able to help people with diabetes live healthier. We're having some success in terms of increasing access, shining a bright light on the health disparities that exist, and slowly untangling those. So I think in the coming years, we hope to see a lot of improvement. The tools are better than ever, and now we need to push for greater adoption.
Well, thank you. Dr. Robert Gabay, Chief Scientific and Medical Officer of the American Diabetes Association. Thanks so much for joining us today and sharing your thoughts, and good luck on all this work. And please come back and give us some updates now and then.
Great. Thank you so much for having me.
My next two guests are experts in diabetes management, health disparities, and the connection between diabetes and obesity. Dr. Felicia Hill-Briggs is Vice President of Prevention at Northwell Health. She's a clinical psychologist and behavioral scientist. Her expertise lies in designing individual-level and systems-level interventions to improve prevention and management of diabetes. And Dr. Scott Kahan is the Director of the National Center for Weight and Wellness and is a physician trained in both medicine and public health. He's advised several Surgeon Generals as well, and members of Congress, governmental agencies on obesity, nutrition, and chronic disease prevention. He's a cool dude. I have enjoyed conversations with both of my guests. Look, let me just start here, Felicia, with a question. I always like to talk with knowledgeable, thoughtful people here. What are the dimensions of this we haven't talked about so far? What are the blind spots in our conversation about understanding how to deliver better health in this country more evenly? What are we missing in our conversation? Educate us.
Yes. Well, I think I agree with Dr. Gabay, who said he's very hopeful and sees reason to hope for where we're headed. I would agree. I'd say one of the largest gaps has been and continues to be, of course, how we achieve equity in care. So as we all know, we have tremendous opportunities with all of our therapeutic innovations, with the data availability, algorithms, machine learning technologies. There are tremendous opportunities to improve diabetes outcomes. However, in each era of innovation, we have seen the persistent pattern that racial and ethnic minorities and people with lower socioeconomic status are not faring as well due to many factors. Access factors, due to what now we're calling social determinants of health. And until we can wrap our heads and our initiatives around this huge phenomenon of social determinants of health, it's going to be very difficult for us to see population level improvements in diabetes care.
Well, Scott, we have talked about this as well, that sometimes the messaging that we've been sending out to people about what they themselves can do in terms of becoming more empowered in this has been out of kilter. And I would love, in your work as well, to ask that same question that I just asked Felicia, which is the question of what are our blind spots? What are the opportunities? What's the low-hanging fruit out there we may not even be thinking of in terms of addressing, again, coming back to the patient who's trying to struggle through all this? What could we be suggesting as part of the package?
Yeah, first of all, I'll say we don't have to look for things that we haven't even been thinking of. We already know a whole lot about this. There's a lot of very good research showing that there's so much that we could do already with the knowledge we have already, with the counseling techniques we have already, with the medications we have already, and even more coming on the line. So one of the things that unfortunately tends to happen is whether doctors talking to patients or whether broader advertisements and communications around behavioral change and eating healthy and weight management, it tends to be nagging often rather than supportive, thoughtful, productive information and support to help people make some changes in their lives. Another of the unfortunate counterproductive messages that can occur is that people have to lose all their weight in order to be healthy and in order to prevent diabetes. They have to get thin or the like. The data we have is very, very different. You lose literally 5, 10, or 15 pounds. And that tends to improve health, it tends to improve quality of life and mobility, and it significantly decreases the risk of getting diabetes if you don't already have it. And if you have diabetes, it already starts to improve it quite a bit. For those people that may not get enough benefit from nutrition and exercise changes and losing some weight, there are medications that are very helpful, both medications that are helpful for diabetes treatment, as well as very good medications that are FDA approved to treat obesity and that have been shown to significantly reduce the risk of getting diabetes by 70 or 80% in some cases. If you're at risk, and also improve diabetes when you have it. So lots that are out there. Unfortunately, we're just not using them as much. We're not getting the word out. Only 2% of people who have an indication for an obesity medication actually use those medications. Same thing with bariatric surgery for people with very severe obesity. Only 1% who are eligible get bariatric surgery. Very few people who are eligible for counseling, basic counseling from their doctor on weight management and prevention. Only about 1% get that counseling. So we need to do a better job of putting what we know into place, even more so than getting new technologies and new options.
So, Scott, what is, let me just give you a quick minute. You talk to Surgeons General, and you talk to a lot of people in this. Why haven't we made that progress in messaging?
Look, there's certainly a lot of reasons. One is some of the people that often would be the figureheads in the messaging, physicians and other healthcare providers, rarely get any training in weight management, in nutrition, in behavioral change. When I was in medical school, just a touch over 2 decades ago, there was nothing. I had an hour lecture on nutrition and weight management, and that was very, very basic. Today, it's not that much better. And I will say, unfortunately, he didn't bring it up, but Rep. Burgess, who you had before, he has co-sponsored a resolution that would increase the importance and hopefully the availability of training in medical school and other health professional training programs around nutrition and prevention and weight management. So that's one of the important reasons. I think another big reason is weight stigma and bias. There are lots of prejudices in our culture, but one of the most prevalent is around people's weight and appearance. And so it tends to lead to doctors either not bringing up weight in the medical office, or often sort of finger wagging and stigmatizing patients about it. It is part of the reason that policymakers tend not to focus on areas of nutrition and obesity and weight management because they often believe that patients just need to, suck it up and be healthy and eat less and exercise more. And it's often, believe it or not, self-directed stigma is also very common. So people who have obesity and diabetes often are so ashamed about it that they don't reach out for help and don't take advantage of some of the opportunities and resources that are available to them. So for those reasons and others, I think that's how I would answer your question.
I appreciate that. Dr. Hill-Briggs, I know this is going to sound like a non sequitur, but folks, it is not. I used to, and I still do a lot of trade policy, commentary and work. And years ago, decades ago, America wasn't running a trade surplus with Korea. We were kind of in a deficit, and we used to talk about it forever. That was Japan. Now China's is huge, et cetera. But eventually that Korea-U.S. trade deficit corrected. It was a change. I want so much the issue of health equity to be like that we actually talking about, if we talk about COVID and the impact on communities of color in this country being disproportionate with, say, the white community in this country is a topic I really wish would go away because we achieve different results. And so I'm wondering, are there any models out there? Did we learn anything from COVID, with the tens of billions of dollars spent on, finding trusted ambassadors, trying to find different ways to communicate, build, going into communities, more differently, whether there's anything there that we can learn from that succeeded, or is this such an endemic problem? And I have to just be honest with people. There's a trust problem between a lot of the health community and certain communities in this country. So I'm just interested in your insights on what we can do to reverse this so we can come back and begin applauding, achievement in health equity.
Yes. So, Steve, I think what's probably most important for all of us to understand is how complex the issue is, how deeply entrenched the issue is, and that it's not a transient or temporary problem.
Right.
There was a point in time during which physicians would see a patient who's homeless or a patient who is food insecure or having difficulty during that visit with paying for their medications. And the physician was mobilized to try to find some social services to help that individual. What we now know, although I don't know if we are fully grasping the severity of this, but what we now know is that these social determinants of health are historical in nature, they are cyclical, they are intergenerational, and they are population-based as opposed to individually based. And so right now our focus has still been a great deal on what can we do for each individual. Let's measure needs of each individual. Let's see what we can do to connect each individual to a set of resources or social services. That is not going to get us all the way where we need to go. These solutions are going to be more complex. Some of the recommendations that we really need to take heed of are really ones that originated with the World Health Organization, who was the first to establish a Commission on Social Determinants of Health, and in 2008 and 2010 put out recommendations that really address the fact that social determinants are systemic in nature. It's about the conditions under which people are born, grow, work, live, and age. And those conditions are influenced by economic structures, political structures. And so in order to address these, both internationally and here within the United States, we have to think bigger than what the healthcare provider can do, and even bigger than what the healthcare system can do. Health in all policies is one approach that promises to bring us closer to what we're striving for by way of equity. And that is that health has to be a part of all decision making at a policy level. It has to be a part of decision making in all sectors. In the housing sector, for example, if housing developments are being built or housing units, there needs to be a source of food accessible to the people who will live in those housing developments. When decisions are made about things such as waste or pollution, health has to be a part of those determinations. We don't want inadvertently to continue disadvantaging low-income neighborhoods or rural areas in having to deal with environmental decision-making and the health impacts of those environmental decisions, for example. So health in all policies is an approach that is being recommended by the American Public Health Association. This is an approach being used internationally, and we need to bring together the sectors and stakeholders to do serious planning beyond only what a healthcare practitioner can do with a given patient on a given day.
That's a very comprehensive answer, so thank you for that. Scott, the other dimension of this, which I know you deal with in your regular practice, are the connections between obesity and diabetes. You know, should we be finding a way from a practitioner's perspective or looking at how we treat and look at it, what the playbook is, of pouring a lot more resources and effort on the front line of those initial diagnoses than we are today? And that includes paying for it, which I know we don't.
So, without question, the broader way of looking at it is we need to move upstream. So rather than just treating diabetes, if we move upstream of that and help people with healthy nutrition, physical activity, and weight management, that significantly decreases the burden of diabetes. And as Felicia was saying, if we move even further upstream from that and help set the stage for healthier living, that will significantly improve the likelihood of people being able to manage weight, eat healthier, live healthier lives, and ultimately improve and reduce diabetes risk. Specifically with respect to obesity treatment, there's so much support for what we can do to improve diabetes by treating and addressing obesity. Good counseling, we heard earlier, the diabetes prevention program, with modest behavioral changes and very small weight losses, we cut the risk of diabetes by 60% in people who have obesity and prediabetes. The medications that we have, FDA-approved medications for obesity now, they cut the risk of developing diabetes for people at risk by 70 or 80% for some of them, as well as other positive outcomes. And bariatric surgery, especially in patients with diabetes, has been shown to be incredibly helpful, not only in weight loss and blood sugar improvement, diabetes improvement, but also in long-term mortality, not dying young. So if we can better address obesity, there's going to be a whole lot of benefits, including with respect to diabetes. Again, a lot of this has to do with broader factors than just what's happening in the clinic. So there's little training of providers, particularly the primary care workforce in obesity management. There's very poor coverage of evidence-based obesity treatments. And the stigma that surrounds it all is another broad societal factor that tends to get in the way of all of this.
I mean, it's a huge thing. We have a question from the audience from the two of you. Let me ask Richard Bailey. Richard?
Hi there. My name's Richard Bailey, and I am an MD, MPH candidate at Case Western Reserve University. My question for the panel is, how is continuous glucose monitoring technology addressing barriers to implementation, and how can this technology be distributed more equitably? Thank you so much for your time.
What a great question, Richard. And I also love the energy. So great. Thank you. Felicia, your thoughts?
Well, continuous glucose monitoring, without question, has been a game changer. Whether you're doing research on outcomes and the impact of time in range and the impact on people with diabetes, feelings of empowerment, understanding of their diabetes, understanding of the relationship between their behavior and their blood glucose levels, CGMs have provided the type of information and the type of autonomy that people with diabetes seek in order to make better decisions.
Felicia, if I can interrupt just for a moment, would you do our audience a favor? Because we have a lot of lay people watching this, and they may not know about continuous glucose monitoring as a device, how it's different with it. Can you just tell our audience a little bit about it, and then how it differs from what pre-existed?
Yes. So continuous glucose monitoring is a way for people to self-monitor their levels of blood sugar. And so traditionally, people would monitor their blood sugar at home using a device wherein they prick their finger, they'd get a drop of blood, they put that drop of blood in the meter, and that meter reads what the blood sugar level is. Continuous glucose monitoring is a system that enables subcutaneous sensor, a sensor that's under the skin that reads blood sugar levels on a continuous basis. And Scott, I may be mistaken, I think depending on the meter, it's about every 6 minutes
so a lot
or
less stabbing.
So a new reading appears. And so you do not have to do that stabbing of your finger, as you're saying, Steve. Instead, you're able to keep this sensor in your skin for a period of days to weeks. And again, it depends on what continuous glucose monitor you have, the number of days or the number of weeks it's able to stay in. And so what's different is that, we know that blood sugar levels change constantly. They can change while you're sitting still at a desk. They certainly change when you're eating or consuming something. They change when you're doing exercise. And when you have to monitor, when you have to stick your finger, people will only know what their blood sugar is at that moment in time. With the continuous glucose monitors, because it's not just a once a day or 4 times a day reading of your blood sugar, you're able to see patterns in how your blood sugar is responding to your activities across the full 24-hour period. That information has been extraordinarily useful for people with diabetes because it acts as biofeedback. You're able to get rather proximate or rather immediate feedback about what you're doing and how it's impacting your blood sugars. It takes, what you'll hear patients say is it takes a lot of mystery out of blood sugar levels and how it got where it was. And people are able to test eating their favorite food and see how it affects their blood sugar so that in the future they know how they may need to adjust their insulin if they're taking insulin, or need to adjust what they're eating or how they're eating, or foods that are really detrimental to them immediately. And so I think for all of us who are practitioners working in diabetes education and care, and for all patient advocates, we really do want to see continuous glucose monitoring available to all patients with diabetes because of that ability to give the patient greater understanding and control over how they manage their disease. It's not only about making decisions about insulin, and it's not only about having their physicians look at their patterns. Those are very important. but at an immediate level,
Right.
it allows patients to make better decisions on a daily basis and learn their bodies.
Right.
And so we tend to see tremendous improvements in blood sugar management with CGMs.
That's very hopeful. Scott, I'm going to give you a chance for the wrap this up with us, but to respond both to Richard's good question, but also look at, are there things we can do to kind of improve equitable distribution? Are there things by way of metrics, by way of biofeedback, in which Felicia just talked about, that you would see as useful out there that we're not doing now? Give us your thoughts in response to Richard Bailey.
Well, in terms of continuous glucose monitoring, Felicia gave a great overview. The problem, as she alluded to at the end, is that it's difficult to get these covered for patients. I can't tell you how many of my patients would benefit from being able to use a CGM, and it's a tiny minority that are able to actually get it covered by insurance. If you don't have diabetes, there's no chance. If you have diabetes, often there's still little chance. You have to have diabetes on insulin and often on quite a lot of insulin, very poorly controlled diabetes, before they'll get covered. And they're expensive little machines, unfortunately. So again, here, this gets back to what I said at the very start, which is, look, we have a lot coming in the pipeline in terms of new technologies and new opportunities. But without even all of that, we know a lot. We have a lot of great resources already. We're just not using them as well as we could be. Some of that needs to be addressed by policy changes. Some of that needs to be addressed by better education of patients with diabetes. Some of it needs to be addressed by better education and knowledge of the doctors and healthcare providers that support their patients who have diabetes. So that's where we need to go, I think, in the most immediate term, and we'll build more from there.
Well, listen, thank you to you both. What a great primer. I'm going to go back and watch this myself just to relearn what you've shared. Dr. Felicia Hill-Briggs, Vice President of Prevention at Northwell Health, and Dr. Scott Kahan, Director of the National Center for Weight and Wellness. Thanks so much for joining me today, and I hope you'll come back soon. It's such an important topic, and really appreciated both of you kind of bringing your A game to this. Thank you.
Thank you.
Thank you.
Well, that brings us to the end of our program today. It's a very important topic. A big thank you to Eli Lilly for its support of these conversations and to all of you who have attended. For anybody who missed this, we're going to have the video of this entire set of conversations on our website shortly. Go watch it, go share it. I'm Steve Clemens. Be well.